That was a really awesome session with Barry. So excited to have all you here. I want to remind you, if you have questions, we'll be monitoring them in the chat. This is a lean in experience. Say hello, share where you are, share where you are physically actually located, so you can connect with other people. And we know it's a little challenging to connect virtually, so lean into the chat and ask questions as we go. I'm very excited about this next session with Dr. Libutti. We have a fireside chat on genomics, on oncology, on innovation, and where this industry is going, where the opportunities are. And so I'm thrilled to welcome Dr. Stephen Libutti. He is the director of the Rutgers Cancer Institute of New Jersey. He's the vice chancellor for cancer programs at Rutgers Biomedical and Health Sciences. And he's also the SVP of Oncology Services for RWJ Health. Dr. Libutti is going to give us a quick intro and background on the opportunity of innovation in this industry, and then we're going to do a bit of a fireside chat. So like I said, if you have questions, please drop them in the chat and I'll do my best to weave them in. And without any further ado, Dr. Libutti, thanks so much for joining us today.
Well, thank you, Aaron, for that introduction. And it's
before
really
you get into it, where are you joining us from?
So I'm joining you from West Harrison, New York. So I'm across the border in New York today.
Hold it against you. And I hope I didn't throw you off your game, but
oh, not at all.
For a few minutes, and I'll be back.
Not at all. So thanks, Aaron. Thanks for that intro, and it's a great pleasure to be with all of you this morning. So, as a bit of background, I kind of look at the evolution of genomic technology, sort of paralleling my career to some degree. I've been in the field of oncology, clinical care, and research now for about 26 years, and I started my career at the National Cancer Institute in Bethesda, Maryland, in 1995, and that was during the heat of the sequencing of the human genome and the work being done by Francis Collins at the NIH and Craig Ventnor, both driving technology to sequence the genome and essentially to give us the blueprint that we use today as we try to better understand disease. I was at the NIH from 1995 to 2009, and when I left and joined Montefiore Health System and the Albert Einstein College of Medicine, we were first beginning to apply the knowledge that we had gained from sequencing the human genome to really affect the development of targeted therapies to treat cancer. And some of the earliest mutations that were identified at that time, BRAF mutations associated with melanoma, or epidermal growth factor receptor mutations associated with lung cancer or colon cancer, were really becoming actionable, meaning we were developing therapeutics. And in 2017, when I joined Rutgers as the director of the Cancer Institute and RWJ Barnabas as senior vice president for oncology services, the sort of payoff of all of that hard work in developing technologies to get accurate sequencing really became very routine. At the Rutgers Cancer Institute, we have a precision medicine program led by Dr. Sridhar Ganesan that holds weekly precision medicine tumor boards across the state. Practitioners, hospital practices, private practices, outpatient practices can log in to that virtual precision medicine tumor board to gain insights about their patients' tumors, what might influence therapy, what might influence clinical trial activity. And so I have seen nothing but excitement around this field as we begin to better understand cancer as a disease by understanding the genetics of those tumors, and then obviously some information about the genetics of the patients that have those tumors. And so that's a bit of my background and how it sort of overlaps with the science and technology around genomics and the progress we've made over the last quarter century.
Awesome. So first of all, you talked about I think you said a cancer board or a tumor board. Can you explain what that actually is? Because I know, as we discussed, a broad audience, and I want to make sure it's as relatable as possible.
Absolutely. So a precision medicine tumor board is nothing more than a group of experts, physicians with an expertise in genetics and genomics at the Rutgers Cancer Institute that receive information from physicians, oncologists around the state on the patients that they may be treating, information about the sequencing of that patient's tumor, some clinical information about the stage of disease and what other characteristics, where did the tumor originate, et cetera. And taking that genetic information that they get from sequencing and some of that clinical information, they're able to make recommendations that those physicians across the state can now utilize in coming up with a treatment plan or deciding if their patients may be candidates for clinical trials. And we make that available across the state.
So I'm going to start with some basic questions, and we'll go in depth as a bit. But why is sequencing the key here? Why does that matter so much?
So for most of the history of oncology, especially the treatment of patients with cancer, we base decisions around what treatments to use on the site of origin of the tumor. And so this is very familiar, I would imagine, to everyone in the audience. Breast cancer treated with different agents compared to pancreas cancer or colon cancer or lung cancer. But what we've learned through sequencing the human genome, and especially sequencing tumors, is that tumors originating in different sites may harbor the same mutations, making those tumors much more alike based on their genetic profile than necessarily just because they originate in the same tissues. So for example, a tumor with a BRAF mutation that originated in the skin as a melanoma versus a tumor that originated, let's say, in the thyroid that has a BRAF mutation may respond to the same agents because they're targeting that BRAF mutation than maybe two lung cancers, one with a specific mutation and one that does not have that specific mutation. And so classifying tumors by their genetic profile as opposed to the site of origin of the tumor is something that we've discovered may lead to the development of new therapeutic approaches.
So how does how does technology play a role here? As you know, part of our focus now is around bringing together what we look at as industry strengths in the region, and the health tech and life sciences industry is one where we believe we have a real strength in New Jersey. And so how do you believe the startup and technology community can play a role in this industry?
So it's a great question. Cancer genetics or genomics is very dependent on technology, and really in two ways. First, actually doing the sequencing. And so I can tell you, when I started my career, as I said, 26 years ago, it could take days to sequence even a small portion of the DNA in a tumor. 500 base pairs, which is a minuscule component of the tumor's genome, could take 2 or 3 days to sequence. Now, with technology, massively parallel sequencing technology, liquid chromatography techniques for doing sequencing, we can sequence tens of thousands of base pairs in short order. We can sequence an entire genome in the time it used to take for us to just get a snapshot of a genome. And this is all based on advances in technology. The other important benefit of these technology advances is bringing the cost of sequencing down. Back 25, 26 years ago, to sequence an entire genome would have been, tens of thousands, if not hundreds of thousands of dollars. Now we can sequence large sections of the tumor for pennies on those dollars in terms of what we were able to do before. So that's one area where technology has been a major benefit. The other is in allowing us to interpret the information that we find. As you can imagine, the amount of data you get out of sequencing a tumor is huge. And to have the bioinformatics and the computing capability to help interpret and translate that information in a way we can hand it to precision medicine tumor boards to be able to make medical decisions is of critical import. So I think those are just two obvious ways that technology has helped us drive this field forward.
It's interesting, when I got involved in the internet business community in the late 90s, one of the major advantages was that server costs were starting to come way, way down. And now you can spin up a website in a matter of hours for very, very little cost. And it reminds me of what you just described about the cost of getting into the market and getting the data is significantly decreased, which often brings with it a variety of economic opportunity. So in thinking about what you just shared, it seems like there may be some real opportunities for those in big data and data science and machine learning to apply those methodologies to this industry. Are you seeing companies that are traditionally in software getting into cancer research and oncology?
Oh, absolutely. There are a number of companies out there that are in this space now, and some that started out more in the sort of the brute force sequencing activity, but have evolved now into the interpretation component of it, the big data piece. So, Tempus is an example of a company in that space, Flatiron, an example of a company in that space. And I think one of the areas that brings together the old and the new is, as physicians, we rely heavily on patient information, patient history, patient physical exam, laboratory data, routine things that you would get, pathology, in the staging of a tumor, a cancer. All of that information traditionally was stored on paper. And now we're evolving into electronic medical records, electronic health records, where that information is not only stored in a computer and printed out like one would use a word processor, but stored in a computer in a way that you can access it, that you can get at that information by labeling it in fields and pulling that information so you can utilize that information more effectively, more efficiently. And so bringing together the traditional information that we need to make a diagnosis for a patient with genomic information and allowing the provider or the practitioner to bridge that gap is a ripe area for technology development and new startups that can help assist coordinating those various pieces of information. Imaging data, imaging has advanced tremendously over the last 25 years. MRI, CT scan, functional imaging like PET scanning, positron emission tomography, which allows us to use a radio-labeled tracer to see the activity of a tumor. Bringing all that imaging data together with pathology data, with clinical history data, and genomic data is really what's enabling us to make better decisions and to create more targeted therapy.
In the startup community, we often talk about building solutions that are inevitabilities, that eventually it makes sense that you should be able to summon a vehicle on your phone because it's more efficient to see who's closest, and then the Uber, the Lyft, et cetera, shows up. What are some near-term inevitabilities that you see technology playing a role in? And I think of this question because what you just described, as a patient occasionally, it's crazy to me that we don't have some of these things digitized yet. I know that there are a variety of significant legal hurdles here, but what do you, besides that, or potentially including that, but what do you see as some of the short-term inevitabilities that you hope to see, in practice in the near future?
So I think it's inevitable that your genetic or genomic information is going to be as routinely carried and accessible with all the appropriate protections that we do for your demographic and clinical information, HIPAA regulations, other things that protect patient information, protect things, like a history of hypertension, a history of heart disease, a history of diabetes, all of that information that you carry around in your medical record that's now part of your electronic health record. I think it will be routine that once the accuracy and the reliability and reproducibility of genetic information is routine, we'll have that information about patients and have the ability to make predictions about response to therapy or health. We certainly are already there to a large degree with tumors. I want to draw an important distinction. Your genetic information, germline genetic information, that is information about your genes, is different than sequencing the genetics of your tumor. When we sequence a tumor, we're really looking for mutations in common genes that we can then act on, either to make a better diagnosis and predict outcome, or to actually match to therapy. But I think at some point in the future, your genetic information, that is, information that might predict, your outcome from an intervention for hypertension, or whether or not you'll respond to a specific intervention for diabetes, will be more common and accessible under the same safeguards. We as a field in medicine are ripe for disruptors. We've been doing things the same way for a long time in terms of how we practice medicine. And I think startups and technology have a role to play in helping us to make advances and move out of the way we've been doing things in the past. And again, to the benefit of our patients.
I'm so glad you brought that up. As you know, we're announcing later this afternoon a $50,000 Better Wellness Challenge, where we're inviting in the startup community to pitch their ideas that advance, the wellness of society. Where there's a focus here on oncology, but in general, looking for startups that are advancing the life sciences industry. But you brought up a point before about, having your sequencing on hand. And so I'm curious, do you think in the way that, I know that my blood type is B positive, I'll have some marker of when I go see a physician, here's my my DNA sequencing?
So I think at some point we're going to get there. A lot of what we learn from sequencing your germline, that is the DNA that's in all your cells, we've yet to make correlations with, in terms of what does it mean if you have a certain gene mutation, or rather than calling it a mutation, a certain difference in a genetic sequence, because there are polymorphisms, which mean differences among people, just like hair color, eye color is driven by differences in genes, so susceptibility to hypertension, diabetes, etc. So once we are better at making those correlations, which is an important role for big data to play, I think there will be a time where we can look at what can we learn from genetic sequence that might help us prevent disease. One of the things that Barry Ostrowski says all the time, and I certainly agree with wholeheartedly, is as a health system, we really need to be in the business of keeping people healthy, avoiding the need to go to a doctor. And I think having more information about genomics, proteomics, metabolomics, and that basic information may allow us to better screen individuals as well as populations and avoid disease. That is by risk mitigation, behavioral change, avoiding certain activities might help us prevent cancer from occurring in a patient. If we could, I'm not saying we have this information now, but if we could, by doing a genetic profile, know that you're at significantly increased risk of developing skin cancer with sun exposure, or lung cancer with smoking, et cetera, and you knew that early on and could avoid those high-risk behaviors and therefore avoid developing those diseases, it's a lot better for patients and a lot less expensive for our citizens if we can prevent disease as opposed to reacting and treating disease. So I do think at some point, when our knowledge catches up to the technology, our ability to sequence, collate that data, when we can actually interpret it and know what it means, I think that'll be an important part of your health record.
Maybe slightly off topic here, but I'm a hardcore Android user, and I get made fun of by a lot of iPhone users, my wife being top of the list. And so the only Apple product that I am jealous of is her watch. I think that the health information that she gets out of the watch is incredible. And I'm curious, and significantly beats the Android watch, which I'm currently wearing, unfortunately. I'm curious if you think that there is an opportunity that at some point there is a more constant health monitoring solution. I'm reminded of this as the watch. I don't know what the form factor would be, that predicts earlier on some of these, not just the risk factors, but maybe exposure, that has you more in touch with potentially your physician? Like, do you see a wearable or any kind of a hardware device changing the healthcare industry and affecting the industry that you're in?
Absolutely. There's no doubt in my mind. And the Apple Watch is a great example. Look at the EKG capability of the Apple Watch, the blood oxygen sensing capability of the Apple Watch. As those technologies get improved and refined, there's no reason why you couldn't be able to, envision a device, even if the watch itself isn't also the measuring device, but is actually receiving and collating that information. You can envision having real-time blood pressure monitoring, real-time, we already have real-time heart rate and EKG monitoring, real-time blood oxygenation monitoring, real-time glucose monitoring, where you don't need to do a finger prick, but you can actually sense it by looking at the optics of the flow in capillaries and reading back color signals that will let you know what your glucose level is or other factors. I think it's only a matter of time in terms of the improvement of those sensors and matching it to battery life and all the other things that we have to do for a wearable. The real, I think, key here, the transition point or inflection points, going to be when that data is reliable enough that it's not just a bit of a gimmick. I mean, I'm not saying the EKG is a gimmick. It's not. It's very good at measuring AFib, and it can give you an alert, to have you call your doctor. But at a point where the data is so accurate and the ability to transmit it so secure that we as physicians can be monitoring that information, almost in real time on individual patients. We do that in clinical trials already. There are devices that we can deploy when we're running a clinical trial to give us all sorts of real-time information on the state of health of our patients. I think that kind of technology, if not taken to an absurd conclusion, can be very helpful, as we try to help people be healthier, to be responsive to those cues and to act on them in real time. I have no doubt that we're going to see more and more of those wearable, medically related capabilities be a part of these, watches and other things that you can easily take around with you.
Are there, again, I'm a little off my topic of expertise, but are there ingestibles? I've seen contact lenses that are connected. Are there ingestibles today on the market? Have you seen, what does the future of this look like?
So there's all sorts of ideas around implantables and ingestibles, et cetera. I'll tell you one ingestible that's really revolutionized our space in terms of cancer diagnosis, and that's pill endoscopy. They're little ingestible cameras that don't stay in permanently. They travel through your GI tract and come out the other end. But they take pictures as they're tumbling and making their way down your GI tract, and we can diagnose early lesions, including early tumor lesions, in areas of the digestive system that are not easily accessible by endoscopy, whether it's upper or lower endoscopy, most notably the small intestine. And so these camera pills or pill endoscopy has been around for a long time now. They actually have little mini sort of GPS systems in them, so you can actually track where they've been in your GI tract and then put that whole map back together for the surgeon or the gastroenterologist to get that information. So I think we're going to see a lot more of that kind of technology make its way either into diagnostic use or even use during a therapeutic operation. We use that kind of technology now in the operating room. I'm a surgeon, a surgical oncologist, and we use all sorts of fluorescent markers and other techniques when we do laparoscopic or robotic surgery to help guide the surgery. And so I think the future is now in a lot of respects in terms of how we've leveraged that kind of technology.
You brought up a variety of issues before that have other implications, and you suggested, with the same level of security as you should expect in other practices. What are the ethical issues that come up with this, the access to this kind of personal data, and how do you see this industry handling that?
Yeah, so I think there's a number of them. I think the first one that always worries me, and I, am always focused on us getting better at, is what do you do with the information? So genetic information is not a guarantee, it's a possibility. It's almost like getting a card reading. You may have a predisposition, but it doesn't mean that's what's going to happen in every case. Some diseases, if you have the mutation, you're pretty much guaranteed you'll ultimately develop the disease. But more often, it indicates a risk, a level of risk. You may, if certain things coalesce, develop the disease, but you may not. And so one of the most important things is making sure that we're able to accurately make predictions, and that the information doesn't get in the hands of folks that may want to narrow your ability to do things or to get certain care with this information that may be less than absolute. And so we have to be careful with respect to that. We also have to be careful with respect to just privacy concerns. Our social security numbers, our credit card information. It's so convenient to do transactions electronically and over the internet, but there's risk associated with it. Folks with nefarious purposes can get access to very important information and use it in a way that is not of benefit to the individual. I think the same risks exist for medical information. And so we just have to make sure that our ability to secure this information catches up and exceeds our ability to gather the information. And I believe we can do that. I believe there are ways we can protect that information and balance out the benefits of knowing versus the risks of inappropriate access.
One thing that we talk about with a variety of our programs is making sure that technology companies and founders are thinking about solutions that have an equitable impact, that we're not building solutions for the few, but for the many. And so as entrepreneurs and investors who are listening here and researchers who are listening here, what would you charge them with? What would you challenge them with in thinking about solutions that have an equitable and equal impact versus those that solve for the few?
So two things. So first and foremost, it's cost. And so the barriers to entry shouldn't be based on cost to the best that we can do that. And we've done that to a large degree with genetic sequencing now for tumors. Genetic sequencing is covered by Medicaid, Medicare. We're able to do it regardless of ability to pay. And I think that has to be our guiding principle. We need to be able to deploy these technologies in a way that it's agnostic to an ability to pay, that we figure out how to do that, whether it's government, healthcare systems like our own, partnerships with the technology entities, that we don't have that socioeconomic barrier to access. The second is to be inclusive of underrepresented populations in how you validate these technologies, because far too often our clinical trials, whether they're focused on genetic or genomic-based medicine or new therapeutics, accrue to those trials folks that are not in those ethnic, socioeconomic, gender, race groups, to give us a well-rounded assessment of what the applications actually are. And I think a sensitivity to that is incredibly important. We have that at the Rutgers Cancer Institute, more broadly at RWJ-Barnabas Health. We are focused on underrepresented communities in terms of not only our delivery of care, but our clinical research programs. And I think this is real important as we develop new technology.
So
we don't want to price it out. We don't want to price anyone out of access.
In the few minutes that we have remaining, I want to talk about some of the entities that you just shared, right? We at Tech United New Jersey are looking to lean in on areas of regional strength. And so we believe that by bringing together some of the bigger corporates, the investors, the educational institutions, we can create differentiated value for each of those stakeholders. And so I'm curious what you see as the role. As you know, RWJ has become a great partner of ours, Rutgers as well. And so I'm curious, what do you see as the role of the collaborators here, and why is that important, or is it important?
Oh, I think it's absolutely important, and for a variety of reasons. We each come to the problem with a different perspective, and as you bring those different perspectives together, I think you're more likely to come up with a solution. We each have complementary strengths, whether those strengths are access to a population. You know, in New Jersey, close to 9 million people in the state, and RWJ-Barnabas is the largest health system, cares for well over half of that population. The Rutgers Cancer Institute of New Jersey, together with RWJ-Barnabas Health, the largest cancer provider in the state. You know, we see 22,000 new cancer patient visits a year across our system. So that's an incredible wealth of touch points. And then, you know, Rutgers, the intellect, the research, the cutting edge translation of findings within the university. Princeton, which is our consortia partner at the Cancer Center. You know, Rutgers, the largest public research university in the state. Princeton, the largest private research university in the state. And then finally, all of the technology startups and mid-size and large biopharma companies in New Jersey, bringing their expertise in technology and development of new therapies or new machines, et cetera. How could we not be successful if we're able to bring all those groups together around a common problem?
I could not agree more. And I think all of the institutions you just shared are part of the Tech United community. And we think we can create outsized value by doing that. And, you know, I think what might be missing there is some of the capital players, and, you know, Tech Council Ventures, which is an associated fund of Tech United, invests heavily in this space. We want to see more startups get involved in this community. And I believe that in partnership with folks like you and Robert Wood Johnson as a whole, and Rutgers and Princeton and others, you know, we can have a value prop to the technology community that is strong and helps build and retain, you know, large technology companies here in the region. Our motto is to build a better future for all, to empower entrepreneurs, instigators, and innovators who do so. I want to thank you for being one of those innovators and for giving us hope that that maybe one day I'll be converted to the Apple Watch with better healthcare data that will be safe and secure.
Well, I'll help push you along with your wife to transition over to the light. So thank you for having me, Aaron. I had a great time.
We really appreciate it. So normally if we're in person, we do a lot of high-fiving. So on the count of three, give me a 1, 2, 3, high five your camera. 1, 2, 3, boom. Dr. Stephen Libutti, we really appreciate all your time today. And of course, outside of the watch, we really appreciate all the incredible work that you're doing. Next up, we have a fantastic discussion on things that tie directly into this conversation with the founders of Dandelion and Data Biologics on ML, AI, and big data and how it impacts wellness. So here it is.